Now it is my pleasure to introduce our next session, Addressing Gaps and Expanding Maternal Health Insurance Coverage. Our dynamic speakers include, just as a reminder, I'm not going to be reading their full bios, but it includes, first of all, Nicole Gonzalez. Nicole is a Dene nurse midwife from the Navajo Nation. Nicole is the founder of Changing Woman Initiatives, which has the mission to empower diverse Indigenous communities to protect cultural birth resiliency and fundamental Indigenous human right to reproductive health, dignity, and justice. Nicole is internationally known as a leading Native American maternal health expert, who uses her knowledge, skills, and wisdom as a nurse midwife to inform innovative changes to maternal health policy and community wellness. Nicole's presentation is titled Off-Roading, Addressing Maternal and Reproductive Healthcare Needs in Developing Healthcare Deserts. Next, we will hear from Jessica Rigler. Jessica is an Arizona native with over 20 years experience which includes various roles with local, state, and federal and international public health agencies. Jessica was with the Arizona Department of Health Services for 14 years, ending her tenure there as Assistant Director for the Division of Public Health Preparedness. In recent years, Jessica worked with the ADHS team to lead critical public health emergency responses, including opioids and COVID-19. Jessica is currently the Staff Vice President of Population Health and Innovation at Blue Cross Blue Shield of Arizona, where she leads strategic initiatives to maintain and improve the health of Blue Cross Blue Shield of Arizona members. Jessica's presentation is titled Blue Cross Blue Shield of Arizona, Advancing Maternal Health Equity. Our third presenter is Rachel Sally. Rachel is the Maternal and Child Health EPSDT Manager with Access. In this capacity, Rachel is responsible for programming and policy for women, birthing people, and children across Arizona who are covered by Medicaid. Prior to joining Access, Rachel worked at the Arizona Department of Health Services as the Immunization Assessment Manager, and then as the Chief for the Office of Chronic Disease. Rachel's presentation is titled Expanding Access Maternal Healthcare Coverage. Please welcome Nicole, Jessica, and Rachel. And I would like to ask the presenters if you all can keep your presentation to about 15 minutes, and that will allow us about 15 to 10 minutes for questions. Thank you. Nicole?
Good afternoon. She'e Nicole Gonzalez Nishe, Glash Chi Nishalento, Tochini Bushes Chin, Shkaisway Disha Chain, Anastasia Chanela. It's an honor to present to you today. I was actually preparing for an hour presentation, so I will try to keep it down to 15 minutes. I might skip over some slides just in regards to time. I labeled my presentation off-roading because a lot of that happens within our organization, Changing Women Initiative, to address the changing landscape around maternal and reproductive health, and especially with emerging healthcare deserts developing in our communities. After listening to some of the presentations before mine, I feel like everyone did a great job of defining health disparities. And so I won't spend so much time talking about that, but more of like implications for someone like myself, who's a nurse midwife who's been practicing in the community for about 11 years. I often pay attention to the data and the information of the changing landscape around reproductive and maternal health, and think about ways to be innovative to address some of these issues. I'm also part of different organizations who are trying to address these issues, and I've been kind of witness to some of the gaps in what we're trying to address from a policy side, from a community birth equity side, and also from like a health system side. And so using all of that, I give this presentation. And it's a little different from what you guys have been hearing so far with all the data sharing that's been happening. I think there's a lot of information about what our health statistics, what our health looks like in our community. but very little opportunity or even innovation around what to do with that to improve those outcomes. And I'm hearing options, a way to do that through policy and through funding, those sort of things. But I'm taking a different approach of like thinking about systems change in a very different way. I really love Abigail Eckhart's statement, "I'm not historically underserved, I'm colonial oppressed and institutionally underserved." As we talk about systemic racism and some of the issues that we deal with in our communities, like that's a real overlying theme in my opinion. Some learning objectives I hope you get out of my presentation is understanding the impact of health disparities on our communities you're serving, the role of health policies play on access to services and funding, defining regenerative design for change making, understanding the importance of problem solving as part of the design, and conceptualizing creative, innovative teams and organizational design to address complex problems. So I might have to pass through some of these slides in thought of time.
Sure, just tell me, keep going.
Okay, so great. As I mentioned, the learning objectives about things I want to cover is understand the impact of health disparities on the communities you're serving, the role of health policies play on access to service and funding, understanding importance of problem solving as part of the design. I mean, these are like overriding themes. It's not like I'm going to touch on them specifically, but things I hope you get out of what I'm talking through. Next slide. And just some language and terms, again, as we talk about our communities and our systems, like understanding the role of structural racism and how we're working and health disparities, and basically, again, woven into the presentation, not specifically obvious through what I'm going to talk about. I really want to play on regenerative design as ability to evolve in its own capacity to build beneficial reciprocal relationships with other systems as a way to kind of get through some of the things I'm going to talk about. Next slide. So I want to talk about maternity care deserts. Next slide. In U.S. maternity care deserts, March of Dimes report 2022, 36% of U.S. counties designate as maternal health care deserts. More than 2.2 million of childbearing age live in maternity care deserts. So it's 1,119 counties are considered maternity care deserts. Areas where there's low or no access affect up to 6.9 million women, almost 500,000 births across the US. And there's been a 5% increase in counties that have less maternity access since 2020. And just take into account this information. Next slide. So Arizona is based on 2020 data. 13.3% of Arizona counties are considered maternity care deserts. So 2 of the 15 counties are maternity care deserts. 13.3 of Arizona counties have low or moderate, not full access to maternity care. So that again, also that's 2 of the 15 counties. As compared to 2019, in Arizona, 80% of counties have higher percent of women without health insurance. So this depends on county to county. And the average uninsured percent of women is age 15 to 44 in Arizona, which is like 13.2% of the population. Next slide. And then inadequate prenatal care, 14.5% is the US rate. New Mexico has 21.4, Arizona has 18.6. And really common markers or prevalence of barriers for those who have issues with accessing care is they don't know they're pregnant, they couldn't get an appointment when they were wanted, didn't have enough money or insurance to get an appointment, do not have insurance card with them, which oftentimes private insurance carriers will turn people away if they don't have insurance at the time of presenting for care, don't have transportation, didn't want anyone to know they were pregnant, and then also the fifth or the bottom was the doctor's office is too far away to access care. So these are common reasons prenatal care access is low in Arizona and New Mexico. Next slide. And then as far as preterm birth rates, they're up from 2011 to versus 2021. So they're both at 10.0% for New Mexico and Arizona. So there hasn't been a decrease. Next slide. We might I might get through this a little bit faster because I wanted to talk about the disbursement of healthcare providers, and I made this pertain to New Mexico and not specifically Arizona, so we'll just bear with me. Next slide. So there are benchmarks in regards to licensed midwives, and there's always a flow of midwives working in the state, midwives leaving, working the state, same with OB providers. This definitely affects access to care for many of our communities. Next slide. And there's many counties, especially in New Mexico, where a lot of the midwives tend to work in the cities. And I think I had seen someone's presentation earlier talk about midwifery policies, and it was focused on CNMs. The interesting thing about CNMs is majority of CNMs work in hospital and work in like rural urban areas. Very few work in rural areas unless it's an IHS facility or a 638 facility, whereas licensed midwives and CPMs actually work further out in other parts of the states. Next slide. In New Mexico, births are attended by midwives 26.4 births versus the US average, which is 10.3. And I know in Arizona, you guys probably have less births attended by midwives, but these are the states that have integrative midwife models. So New Mexico, Oregon, Washington have really integrative midwifery care models, which has improved our maternal health care in our state. Next slide. So in regards to health policy implications, next slide. There's the global maternal reproductive health. So last year I traveled to United Nations to report on our reproductive justice in the United States. And basically these are our recommendations to remove barriers to accessible, high quality, comprehensive reproductive health care, address and eliminate racial intersectional discrimination in reproductive health care, halt and remedy retrogression of the right to abortion, ensure abortion access, address the impact of environmental racism on reproductive health care. And I heard some of these things being addressed in other people's presentations, but know that on a global scale in the United Nations, like these are also concerns on a global level. Next slide. And I'm also seeing like state and federal policies being implemented around improving maternal health care in rural areas and diversifying our maternal health workforce. And I'm seeing this, like I said, nationally, globally, and on a state level. Next slide. And these are some policies that are trying to improve Medicaid coverage for childbearing people, the Mommies Act and the Momnibus Act. Next slide. Okay, so I wanted to give this information more or less to give an overview of the landscape that we're working through and some of the things I think about when it comes to improving maternal health care. And what I'm seeing is when it comes to systems change, which we're all invested in our different ways, is the policy folks and the hospital folks are having a conversation around systems change, and then the community health folks and the home birth midwives and the birth centers are having their own conversation about that. And then there's also this discussion around decentralizing systems so that we can improve health outcomes. So some of these things for me fall into this regenerative design model where we actually take into account behaviors and owning our own part in things. And so when we talk about systems not working appropriately or they're dysfunctional, a lot of this also has to do with our own behaviors as healthcare providers, as people working in admin, people working in policies. And unfortunately, we continue to recreate systems that don't serve our community and become very oppressive in dynamics because we haven't done a work within ourselves to heal, but also the systems that we're creating don't take into account our own behavioral patterns and our own trauma as part of the problem. And so thinking about this, next slide, and if we're creating a different system, whether it's a nonprofit or business or policy change, like this regenerative design process where it takes into account reflection and integration, analysis and our purpose and our goals to do as intended, right? This is part of the design process that I'm talking about. Next slide. And so I use Changing Woman as actually a case study for this process of regenerative design. So our mission is to empower our diverse Indigenous communities to protect cultural birth resiliency and the fundamental Indigenous human right to reproductive health and dignity and justice. We were founded in 2015, next slide, with the purpose intention to provide affordable care and increase Native American Indigenous birth workforce. 2, improving the health of Native American Indigenous birthing families through the birth and ceremony. 3, supporting Native American Indigenous birth families navigating complex healthcare systems. This picture of the New Mexico in the map shows the areas that we're serving. Next slide. It's basically Santa Fe, Albuquerque, 8 northern Pueblo tribes, 10 southern Pueblo tribes, Gallup, and then part of the Navajo Nation border. And to also know that our goal isn't always home birth. Our goal is to advocate for support and encourage and communicate and listen and support where birth might be best for them. So whether our community is birthing in a hospital, birthing in a birthing suite, choosing a traditional Hogan birth or a home birth, we are providing co-care and collaboration with where the safest place for them to have a baby is. Next slide. How this is different though is, as I talked about when we are talking about systems change, a lot of Native women are birthing in hospital because that's the only choice or the option they have. I think someone had asked a question about IHS providing funding or extending services to include midwifery services. And I know certified nurse midwives have a long history of providing care within the IHS model, but the IHS model doesn't incorporate birth centers, licensed midwives, or certified professional midwives. And also as I'm listening to state strategies to improving maternal health, they're really focused on hospitals and rural communities, but they're not including birth centers, licensed midwives, and CPNs as part of their strategy. And the reason I say this is important is because licensed midwives and certified professionals are specifically trained in low resource communities and also low technology. And so their model is to go into people's home and provide service and care, give education. It's based on a wellness framework. They have training and education on referral processes and nutrition in a way that a lot of folks within a hospital system maybe don't incorporate some of those things. And so one of our measures of success where we are different is, yes, we provide birth service in people's home, which is a home birth model. We also have a birthing suite, which provides a space for people to have their baby who want to be in the city, but maybe not in a hospital setting. This is very different from a birth center model or a home birth situation because our measures of success look different because we're choosing to take care of people who are Native American, low income, BIPOC folks, uninsured folks, people who have issues accessing care. And so when you take care of that population, like the outcome and success isn't always home birth, but that they get a respectful birth whatever setting they're choosing. And so our measures of success are getting people into care early, 2, connecting birth families to needed resources, 3, supporting breastfeeding beyond 6 weeks, 4, collaborating with multiple hospital locations, clients so their healthcare needs are met, and integrating nutrition and traditional medicine as part of the care. Again, looking at the needs of the community, a lot of times businesses and organizations focus their services based on reimbursement for insurance or whether it's a fundable service. Unfortunately, because the majority of our communities are Medicaid insured, funding care is not a profitable thing, right? And so it's going to have to be underwritten somehow, or expansion of Medicaid reimbursement for services is going to have to happen. And that's what's contributing to our healthcare deserts and why labor and delivery services are closing, is because the labor and delivery services are not able, they're getting reimbursed through Medicaid rates, which isn't enough to be sustainable to provide service to everybody. And so how are we going to be sustainable in serving a population where 75% of our community is Medicaid insured? That's the question. Next page. Another part of the organization is community engagement. And so when we talk about resources and training our community to be doulas and lactation consultants, a lot of times people who have limited service and access to care are like in rural areas that don't have maybe a clinic or hospital, but also don't have people skilled and trained to give lactation support or doula support if hospital is the only option for them. And so thinking about training community to be advocates, but also a resource in their community to improve maternal health. And I know there's different programs looking at this in different ways, like community health workers being trained as doulas situation. But this is another opportunity, as I call it, off-roading, to implement resources through training in a community. So like Cami and Kim's Indigenous peer counselor training, right? They train people to be lactation counselors. There's also an Indigenous doula training that we bring in to train folks to be doulas to help people navigate their healthcare system as a way to provide education and advocacy for the families in those areas. So that's the community engagement piece, because community is really interested actually in birth work and want to be involved, but also may not have the resources to go to a 4-year or a 10-year education track, but can get skills and training in a community that is based on traditional wisdom and knowledge. Next page. So another branch of our work is Native American maternal reproductive health policy, because we provide direct services through a maternal health program, as well as our community engagement. We do community education, and then now the health policy piece. So expanding health access for Native American people through legislative advocacy is one thing. As I saw people presenting, we have a high rate of maternal mortality for Native people. We have a high rate of Native people not accessing care in the first trimester. We have women who have preterm rates of birth, and those rates haven't changed, they've increased. So like, what are we doing on an advocacy level for Native people? That's a question, right? Addressing health inequities that disproportionately impact Native American communities. These are all our focus priority areas. And unfortunately, I'm not seeing a lot of tribes jump on board with some of these issues. They are now starting to become aware that maternal health is an issue. And so being part of those health policy decisions around where funding's going to go. I know Arizona got some funding through HRSA to improve maternal health. And I believe one of the reasons your state got that funding is because you included tribes as partners as improving maternal health in your community. And so that to me is like a step in the right direction, but also having how are tribes involved in health policy, improving maternal health. Next page. Oh, this is a little different, sorry. Some things that are a little different about Changing Woman is we have a shared leadership model, and this also speaks to what I was talking about, a decentralized leadership model. So we have a consensus board, meaning we all make decisions and discuss before decisions made. Directors work directly with our board of directors. So our board of directors are actually involved in all of our service and care. So we have a team mentality. We have 4 directors and 5 board members. And so we don't have an executive director. And that's intentionally because unfortunately our systems create hierarchies, which when we talk about systemic racism and we talk about shifting power dynamics, like it really does matter how you create your organization to do the work that it's intended. And so we chose a shared leadership model because we felt like that reflected how our community is makes decisions and governs themselves in our state of New Mexico and Navajo Nation. Next slide. So some of the challenge we faced with getting here is me as the founder having unawareness of how my own personal trauma affected and is affecting cohesive working relationships. Founding board and many after unaware of the difference between working board and established board. And this affected the capacity to carry out the work that was unclear. Many thought it was like stepping into established board when many documents need to be created. There's old paradigms of governing and decision-making that don't work when trying to create something new. As we're talking about implementing these policies and funding and awareness, about maternal health, are the structures that we're currently working in reflecting what we're talking about, right? We talk about racism, we talk about hierarchy, we talk about power, but if our structures still reflect those things, how do they carry those out? And we need to think about how those can change. Power dynamics between board and founder made forward movement ineffective and challenging. So a lot of what we dealt with early on with Changing Women, because we've been now established for 8 years, is that there are power dynamics between board and staff. And so like, how do we distinguish those power dynamics and also be accountable to the work that we're supposed to be doing? Unfortunately, a lot of people who are wanting to do community work, there's lots of community gossip that create closed doors. And especially if prior staff who themselves were unhealthy, didn't contribute to the vision of the organization, they leave and then they muddy the water to build relationships in the community. So anybody who's wanting to do innovative work or a nonprofit model, like grassroots, like these are some of the challenges that are often faced, and that's why many are not successful. Next slide. Some of the things we learned in the last 8 years is that as we encourage and support personal health practices in all forms, it improves our relationships with one another. 3, active, involved, board aware of where they end and where staff begins without micromanaging the team. Allows us to move quickly. Organizational culture shifts happen when you hire the right people. We're still figuring out why ours works. Everyone is independent, driven, self-aware, and compassionate. We work well together because we support personal wellness, but also have an awareness of our trauma and have policies in place to support family, breastfeeding, time off, and also an awareness that we engage trauma every day in the work that we do in our community. And so how is the organization supporting what we engage in a community setting to support our wellness when we come back? Creating infrastructure that is informed by the impact of bidirectional trauma supports compassionate care for staff and clients, which I just talked about. Mutual respect and shared decision-making power builds a stronger team than having one person in charge of everyone. We had a situation 2 years ago where we had an ED and it didn't work out well. And unfortunately, when one person holds so much power and they leave, it can leave the organization vulnerable. And so often as I sit on boards and I work with other nonprofits and organizations, they want to put an ED in power, and then they're disappointed when it doesn't work, or if the ED doesn't share the vision of the board or the community. And really thinking about a decentralized leadership model actually makes the organization stronger, because then you have 4 or 5 people carrying the mission and the vision and making decisions together, and you're not just dependent on one person to lead and to move things forward. And so that was a learning opportunity for us. Super also important is to have rest and downtime, because it affects the morale and dynamics of our team. A lot of the women that work within our organization are moms. They've had babies, they have families. They're also very active in their community as involved in their traditional activities. And so being able to work together and know that they can take time off. We also allow kids to come. So if somebody's kid needs to come while they're out of school and mom works, they're allowed to do that. So there's a lot of opportunities to create safe working environment, supportive working environment that supports the moms. And so when I hear people talking about decolonization, or even advocating for pregnant women in the working environments, like these policies we're talking about, do these policies actually, as you push them out there, right, are you implementing them within your own organization? Are you creating structures that are equitable to your staff and to your team? And I feel like this is missing, and this is why, as I hear all this information, you have to create an organizational system that's healthy, as well as what you're putting out there, implementing some of this within your own system. Next slide. I just want to leave this with, it's not impossible to create a system like this. I know I kind of went all over the place. My work really is in innovation and organizational design and leadership development, because some of the things I learned in my journey becoming and being the founder of Change Initiative is, yes, looking at the larger systems issues, seeing the implementation of policy change, building relationships in the community, having worked in a hospital system and then shifted into a community space, really seeing the challenges with communication and assumptions made about each other, as well as like understanding everybody's skill set. And what I continue to see, as I mentioned before, is birth centers, LMs and CPMs are being left out of the maternal health policy strategy to improve maternal health in our communities. And I know there's a lot of us still struggling to change systems, but I think it's important to also know that we have power to enforce policy. We have power to change policy, but also we have to acknowledge that we're part of the problem too. If we have unhealed trauma or unhealed understanding of what power is supposed to look like in our communities. So yeah, thank you so much for allowing me to present a little piece of what I do. There's some references here, and I will leave it off to the next person.
Yeah, thank you so much, Nicole. There was a lot of positive feedback that was coming in through the chat while you were presenting, in particular around your shared leadership and decision making. So thank you so much for sharing that insight. So we're going to move over to our next presenter. If you have questions for Nicole, please put them in the chat. We'll be able to get to those at the end of the presentation. So our next presenter is Jessica Rigler. Jessica?
Thank you so much, Patricia. Okay. Can you all see my screen?
Yes.
Perfect. Thank you. Nicole, that was a fabulous presentation and very inspiring. It's a hard act to follow, certainly. And I'm going to just completely change directions from what you talked about too, I think. But thank you so much for those words, and to all the speakers that have come before too. Just what an incredible day so far. So just to jump into my presentation, I'm with Blue Cross Blue Shield of Arizona, and I'm here to talk a little bit about our maternal health equity strategy and the work that we've launched recently to this end. So I have nothing to disclose. I just wanted to start very quickly by giving folks an overview of Blue Cross Blue Shield of Arizona, just so we're all grounded in the same information. The Blue Cross Blue Shield companies are all locally operated, and so we're one of 34 of those locally operated companies, and the majority of our staff work here in Arizona. Our health plan is a nonprofit, and we've got about 80 years in the market serving Arizonans. As of this year, there's about 2 million members on our health plan as well, and so we've got pretty broad coverage across the state. And we have health plans that kind of span the gamut when you think about insurance coverage. So we offer a Medicaid or an Access health plan, and we also serve Medicare members. We've got a federal employee program. We provide individual insurance through the Affordable Care Act, the Marketplace, or the Exchange, and then of course employer-sponsored insurance too. And then another thing that I really love to highlight about our organization is our foundation. We do operate the Arizona Foundation for Community and Health Advancement, which is its own 501c3 private non-operating foundation. And this foundation really works to make bold commitments and investments in service of Arizona's diverse communities, structuring all of those investments to serve the public good. Really, the focus is on investing in the health of our state. So the work that the foundation does joins up change makers and innovators, problem solvers, all with that shared goal of making communities healthier across Arizona and looking at chronic conditions, mental health and substance use disorder, and health equity as some of our flagship areas. So we work to amplify impact together in partnership with all of these other organizations across the state. Okay. So now to dive into just the maternal health equity strategy at a high level, I mentioned that Blue Cross Blue Shield of Arizona is one of 34 independent companies through Blue Cross Blue Shield. We belong to a national association, though, that kind of is the umbrella organization over all of those independent companies. And through that work, there's been recognition of this need for meaningful actions to combat the maternal health crisis in the US, particularly when we look at the disparities in birth outcomes. We've set a goal across the Blue Cross Blue Shield family of companies to reduce racial disparities in maternal health by 50% in 5 years. And what you can see on the screen here are the top 10 maternal health equity actions that the Blue Cross and Blue Shield companies have called upon leaders in public and private sectors to join us in addressing. I'm not going to talk about all of these today, but they're incorporated into our action plan. Today, I'm just going to focus on a couple of examples of things that we're doing. So here at AZ Blue, we have our own specific action plan, our maternal health equity action plan that's guided by an internal steering committee here. And again, mirroring with the association's goal, we're looking to reduce racial disparities in maternal health by 50% in 5 years. And you can see the objectives for this on the screen. I'll talk about some examples around these objectives in a little more depth. But at a broad level, we're looking to reduce inequities in maternal experience and support. And that gets at a lot of the things that have been talked about previously today and how we can expand that birthing workforce model and making sure that there's connections made for pregnant people. We're also looking to reduce inequities in quality and safety of care so we can reduce unnecessary harm. One of the ways we do that is through participation on the Arizona AIM steering committee. And I know you'll hear more about that from Vicki tomorrow. We also are working to reduce inequities in the access to and use of care across the maternal continuum. And that looks at things like, how do we increase access to vaccinations? And also broader than that, behavioral health services. How do we make sure that we're not just thinking about maternal care as labor and delivery or prenatal visits, but really across the services that are necessary in order to support pregnant people. So I'll highlight next a couple of the core action plan initiatives that are planned or that are currently underway as a piece of the work that we're doing. And the first is really focused on maternal support services. So on our path to reduce inequities in maternal experience and support, we're exploring strategies to increase access to maternal support services across the continuum. And we've talked a lot about what that continuum looks like today already. As part of our network strategy, we are partnering with provider practices that are interested in being designated as a patient-centered medical home, otherwise known as PCMH. And I know we've talked about that a little bit today too. Through this program, though, we do have AZ Blue providers who are specialty practices that are designated patient-centered medical home practices, specifically in the OBGYN space. And having this quality designation distinguishes providers who have committed to really providing that whole person healthcare, making sure there's coordination against different provider types, personalization and care planning, and then also as a participation in that program requires that those provider groups report specific quality measures to us. Those are things like prenatal and postpartum visit rates, completion of recommended screenings, and C-section and prematurity rates so that we can monitor those and work on identifying where there might be opportunities to provide some additional support. Another part of our network strategy is looking at credentialing and contracting with other providers who are part of the maternal health continuum. In order to be a participating network provider, there's first a credentialing process that has to occur. And so one of the spaces we're looking at right now is doulas. Now that doulas can obtain licensure from ADHS, we're working on our plan to identify that path to credentialing so that these important care team members can be covered in network by a member's health insurance plan. And just the credentialing and coverage alone, we know it doesn't necessarily increase access. There's a lot more to it, but those are the first steps that we're on in order to get there. And then we've also had discussions with Postpartum Support International about perinatal mental health specialists, including how we can promote the services of these providers. And we're just now in the very early stages of discussing internally how they can be recognized in our network in alignment with the recommendations in the statewide plan that was presented this morning. Midwives are another area that we continue to look at to make sure that there's good coverage and then following coverage accessibility in the network. And then from the behavioral health continuum, as we think about that too, we're also working on increasing the utilization of collaborative care in the network. We do cover collaborative care codes here, but one of our action plans for behavioral health is really looking at how we can enhance the utilization of those codes in practice. Next, I'll shift to another one of our initiatives under our action plan, which is focused on high-risk maternity care management. This program is a service that we offer at no cost to members with a high-risk pregnancy. And through this, our supportive care managers reach out to eligible members to provide them with education and support. During that outreach, our care managers are doing assessments with the members so they can really understand their comprehensive situation and needs. That includes the behavioral health assessments, also social determinants of health assessments, really, again, trying to focus on that whole person health, making sure that we're identifying the most critical needs and extending support there. Based on the member's needs, an experienced maternity nurse will work with the member to provide care coordination and additional education and support. And that can look like linkages to other resources, right? Like if there's identified social determinants of health, like insecurities in food or housing or transportation, then we can help to provide linkages to those resources. Also support care navigation to in-network providers that offer any additional services that the member might need, and really help to provide that technical assistance. Our care managers in our high-risk maternity program are incredibly supportive of these members and very successful in reaching and working with them. So nearly 100% of the members that we outreach to are engaged in this care planning process and are able to achieve the goals that they're setting collaboratively with their care member or the care manager, excuse me. We use internal data from claims to identify members who could be eligible for this program, but we also work really closely with provider offices so we can receive referrals for patients that they believe might benefit from the program. And so there's really no wrong door to get engaged in that program for our members. We want to make sure that we're serving as many people as possible in this high-risk maternity program. Okay, so another one of our core strategies to improve maternal health equity is a look at implicit bias training. We know that implicit bias can inadvertently or affect access to healthcare and to health outcomes. And so the Association for Blue Cross Blue Shield has partnered with the March of Dimes, and we've now been in conversations at Easy Blue with the March of Dimes to look at offering their Awareness to Action e-learning program in the coming months. We're getting pretty close to being able to roll this out, but this is an opportunity that will be available to provider offices across the maternal care continuum with a focus on outpatient providers, and participants will earn CMEs or CEUs for their participation in this opportunity. We're really hoping that we can target kind of across the spectrum of provider types. So we're not just looking at prescribers or OBs, but really implicit bias training for anyone that a pregnant person might interact with, from the front desk staff to the MA to the nurses to the prescribers across that entire continuum. And our hope with this program is to complement the work that's already underway and has been taking place for several years in the state through ADHS and the AIM Collaborative, to ensure as many providers as possible have access to these kinds of training resources at no cost. The final component of our action plan I'll highlight today will focus on the activities of our philanthropic arm. I know I gave you a very quick overview of our foundation at the beginning of this presentation, but just to speak a little bit more to it, we're really committed to building that collective impact to address maternal health here in Arizona. And so we have made philanthropic investments through our, sorry, my lights turned off, through our corporate giving, our Mobilize Arizona initiative, and also now through our Foundation for Community and Health Advancement. And through these investments, we funded grants that address maternal health through the lens of substance use disorder, mental health, and other social drivers of health. We award these grants to nonprofit organizations that expand programming or provide direct service, develop innovative initiatives, or are conducting applied research that are making a measurable impact on the lives of Arizonans. For instance, many of these grants target women who are pregnant or postpartum and have a diagnosed substance use and or mental health condition. We saw that talk from Hushabai earlier. They are one of our grantees. And these activities typically provide support and services to improve the health of the mother and the child, as well as looking at those social drivers of health like housing or food insecurity or employment. If you're interested, I would really strongly encourage you to visit azbluefoundation.org to sign up for alerts when new funding opportunities are released. And in fact, just this week, we released a new funding opportunity. It's open through September 15th, and it's looking for applications for programs or applied research that focus on mental health, substance use disorder, chronic health conditions, or health equity. And we just wrapped up a round of funding specifically focused on mental health and substance use disorder as well. So check out azbluefoundation.org and you can get updates in your inbox about that. I'll wrap up by just talking about some future initiatives. I've given you a snapshot of some of the work that we're doing around maternal health, but there's a lot more to come. This includes things like continuing to drive strategies to increase maternal provider participation in the network and expanding the diversity of the types of maternal providers that we're contracted with. Also continuing to review our quality data so we can identify those areas of impact and where we might play a unique role in impacting this space. We also are looking at some pilot programs around peer support and self-management strategies, working with the closed loop referral system in order to integrate that into our work so that we can use the community cares platform to do closed loop referrals through our care management programs. And then we also sponsor provider trainings. So Easy Blue partners with the NARPA Institute to offer Arizona Community Grand Rounds, which are trainings for providers and public health professionals, typically the first Wednesday of every month from noon to 1, and there's free CEUs associated with those. But I'll just plug our next one. It's coming up on September the 6th from 12 to 1. And it's actually focused on maternal mental health and best practices and Arizona resources here. And it'll feature speakers from Postpartum Support International and from the Arizona Perinatal Access Line. So if you want to check that out, you can just Google Arizona Community Grand Rounds and you'll go to the page where you can sign up to receive updates or register for that particular learning opportunity. So with that, I will wrap it up. And I think we'll hold for questions, but I'll turn it back over to Patricia. Thank you so much.
Thank you, Jessica. That was a wonderful presentation. Really excited to hear about all of your investments and ongoing commitment to Arizona residents. It's really great to hear. So our next presentation is going to be by Rachel Sally. So I'd like to bring Rachel up to the screen.
My next slide, I think, is just the disclosure slide. I work for Access, which is a state government agency, and I have no conflicts of interest to disclose. And my next slide, I believe, just gives a summary of some of the things we'll be discussing today. I am going to touch very, very briefly on these things. I could talk about all of them for a very long time, but within 15 minutes, and I know we're a little behind, they're just going to be very brief overviews. And I will give you my email address at the end of this. So if you have conversations or you'd like to learn more information about anything, please feel free to reach out to me and I'd be happy to elaborate at that time. And with that, I think we can go to my first topic, which is postpartum coverage expansion. I know this has been mentioned a few times so far in the conference, and I will explain a little bit more about how this works in another slide, but I wanted to start with the why behind this expansion. And I know you saw a lot of great statistics when Aubrey presented earlier, and I wanted to highlight this one because, as you can see, nearly 60% of maternal deaths occurred more than 6 weeks post-pregnancy. And 89% of these deaths were deemed to be preventable. And while healthcare coverage, as a few people have stated so far, is not the end all be all, we know that it is certainly a factor in reducing mortality and morbidity in our maternal health population. And so ending that coverage at 60 days is certainly doing a disservice. And another factor I wanted to highlight on the next slide is that nearly 1/3 of pregnancy-related deaths involve mental health conditions as an underlying cause of death. And the reason that I mention this, that these conditions are not always detected early on, like a pregnancy complication or a delivery complication might be. And there are a few different reasons for this. One is that sometimes parents try to wait it out. They might be thinking, well, I don't feel right, but maybe once my baby starts sleeping through the night and I'm sleeping, I'll feel better. Or once I get the hang of parenthood, I'll feel better. And sometimes those things do help, but oftentimes that's not the end solution. And another reason for this delay is that sometimes people don't even know that that's what they're experiencing. As Joy mentioned earlier, there's a lot of confusion around maternal mental health. So people might be, thinking that it's normal or that it'll go away, and they don't realize they have a treatable condition until they get screened by a provider, which often doesn't happen until 6 weeks or even later postpartum. And on my next slide, go into more of how this works. So first of all, to clarify, the population that we're referring to is people who are eligible for access on the basis of pregnancy. There are a number of different kind of pathways to eligibility, and they all have income caps, but those income caps are different. So in this case, we're referring to people that are eligible solely based on pregnancy. And previously, this coverage would have ended 60 days after the end of their pregnancy. But with this extension, which was implemented as of April 1st of this year, the coverage now extends until the end of the 12th month after the pregnancy ends. And this coverage is also not limited to postpartum care, even though that's kind of how we think about it and how we talk about it. All covered services are available as long as they are covered through the end of that 12th month. And on the next slide, we discuss some outreach and communication that went out about this. A lot of the communication to our members comes directly from the health plans that we contract with, so that may look a little bit different depending on the plan. But as far as information that was communicated directly from Access, we had a website update, a press release, a monthly newsletter that has over 2,000 subscribers, and of course, social media reach. I know a number of people have mentioned social media and meeting moms where they're at. And this is where most people are at, not just young moms, not just moms. I think all of us probably use social media in some context. And this is where some people get the majority of their news. So it's really important that we reach them through this way too. And now we had told you it was a brief overview. So we're next going to move on to postpartum depression screening and EPSDT visits. And some of you might be wondering what EPSDT means. We love acronyms in public health and healthcare, and this one stands for Early and Periodic Screening, Diagnostic, and Treatment. And what this essentially means is comprehensive and preventive healthcare services for children under the age of 21 who are enrolled in Medicaid. And you also might see the term EPSDT visit, which you can consider to be synonymous with well-child visit, even though EPSDT covers much more than just well-child visits for the purposes of this slide and what we're going to talk about. I just wanted to level set for that. And the way this works is that when a child is brought into their pediatrician or their PCP, the mother or birthing parent is offered this postpartum depression screen at the 1, 2, 4, and 6 month EPSDT visits. And in the event of a positive screen, the parent is provided with referral and information, and the health plan is also notified to make sure that they close that loop and help get the parent connected to services. And free training is also available from the American Academy of Pediatrics to provide more information to providers and help them feel confident when they're doing this assessment of the birthing parent or the mother. And some people might question why we would screen the parent at the baby's appointment. I know most of the people in this conference probably already know this answer, but I included this quote from the American Academy of Pediatrics, which I will not read word to word in an interest of time, but I think it really brings home the point that when a mother or a parent is suffering from depression, they're not the only one suffering, and that we know there's a lot of research that children who are being cared for by a parent with untreated depression have physical and mental health risks that can potentially last a lifetime. And we also know that our population is at especially increased risk, while postpartum depression, just like any mental health struggle, can affect anyone at any income level. Our low income individuals that are covered by Medicaid are at an increased risk. And next, we're going to talk about maternity care reimbursement, particularly in the context of the global OB bundle, which I will explain on the next slide. What the global OB bundle, or sometimes called the maternity bundle or the maternity package, is essentially a method of reimbursement for providers in which they are paid one lump sum that includes care from prenatal care through the delivery and through postpartum care, rather than being reimbursed on like a fee-for-service basis. And in order to be eligible for this, the provider does have to see the member for 5 or more visits. So if they are, say, just covering the delivery, or maybe they saw them for 1 or 2 visits before the member switched providers or moved, then they'll just be billing on a fee-for-service basis, depending on what service they actually provided. And other things that might be billed separately would be a consultation with a specialist or any other service that is medically necessary but is not part of normal expected maternity care. And these are the rates. I wanted to show you here, really looking at the difference between what they used to be and what they are now. As some of you may know, in October of 2022, the reimbursement rates for the global OB codes were increased by about 88%. And as Nicole was stating, we know that reimbursement is often a factor, a decision-making factor for providers in whether or not they want to be contracted in the access network. So our hope is that this increase would incentivize providers to join our network, which ultimately provides more maternity care providers for our members, and hopefully, you know, as a few others have stated, is just one factor, one step in reducing these maternal mortality and morbidity rates that are so high in our state. And next, I'm just going to touch on a few other access maternal and child health initiatives that we've got going on. This one is the Health Plan Performance Improvement Project, also known as a PIP for prenatal and postpartum care. This is a very wordy slide, which I don't usually like to do. But the reason this is wordy is because I am not the SME on PIPs. That is our fabulous QI team. So I had them help me with this slide to ensure that you're getting the most accurate information. And I also promise not to read this to you word for word. But essentially what this is the purpose is to improve health outcomes for pregnant members and their babies by increasing the number of members who receive prenatal and postpartum care visits. So the way this works is that our health plans, our MCOs, are implementing interventions to try to increase these rates. And the specific intervention might vary from health plan to health plan because they all serve different populations. But they measure their baseline data, they implement the intervention, and then measure the data after this has been implemented, and then make decisions about, you know, whether we need to change course or whether this intervention is working to make a difference in increasing their rates of prenatal and postpartum care utilization. And the last thing I wanted to touch on is the Arizona Perinatal Psychiatry Access Line, or APAL. This is an access funded partnership with the University of Arizona. And I know that you will be hearing from the fabulous Dr. Kalia tomorrow, and I know she will probably go into much more detail about APAL, but I just wanted to touch on this. It is a telephone line that connects healthcare providers with specialists, perinatal psychiatrists, for consultation for their pregnant and postpartum patients. We know that even the most experienced physicians might have limited experience with pregnancy or breastfeeding. And this telephone line allows them to connect with people who do have that specialization, perinatal psychiatrists, to help them make decisions about medication and what would be best for their pregnant or postpartum patients that have mental health or substance use concerns. They are also doing data collection. As much data as we have, we know that we still need more. And so I'm really looking forward to seeing what some of that data looks like once this has been implemented long enough to have some meaningful data from it. And they also have free resources available on their webpage, as well as free training that I believe can be either in person or virtual for providers and provider practices. And again, you'll hear a lot more about this, I think, tomorrow. And with that, this is my email address. Please feel free to contact me if you don't get a question answered today, or you think of it later or next month or whenever it comes. I am happy to have any discussions.
Thank you so much, Rachel. We actually do have one question that came in for you. The question reads, if I heard correctly, the health plan does follow up on a positive postpartum depression screening done at the EPSDT visit. When a birthing parent screens positive for postpartum depression and is given a referral for service, how is the health plan notified when documentation is happening within the EPSDT visit of the child's electronic medical record? Is there a workflow for this to be implemented so that the health plan is now informed for follow-up?
The provider notifies the health plan, so the pediatrician or whoever the child's PCP is would be notifying the health plan. Mothers and babies are typically on the same health plan. As far as specific workflow, that might look a little bit different plan to plan. So there's not a specific step-by-step that all of them would follow.
Thank you. We have a follow-up question, Rachel, for you. So with the expanded postpartum coverage, are OBs now an appropriate referral resource after the 6-week postpartum visit? Does the OB package include more than one postpartum visit?
Well, yes. So through that 12th month after the delivery or the end of the pregnancy, prenatal care visits would definitely be included in there. And as I stated before, other services, any covered service is covered for that entire year. It's really just about the person being covered by access longer. So it doesn't limit which services they're being covered. It expands it, really. Expansion is really a great word. It covers all of it.
Thank you. Another question, of course, Rachel, we have a couple coming in for you. Does access cover dental during pregnancy?
So right now, dental services for EPSDT members. So again, if they're under the age of 21, which might include some pregnant members, is comprehensive. And so that applies to anyone in that age group. For adults over the age of 21, it is much more limited. I believe it's like an emergency only. And I know there's a maximum. Adults who are not pregnant or postpartum is not my area of specialty, but I can find out. I've been asked this question a lot, and I've asked this question too, why it hasn't been expanded to pregnant people over the age of 21. And that is that we need legislative approval for that. And we have not yet been successful in getting it, but we're working on that. But, once we get to that state, it's a little bit out of our hands.
Yeah, thank you, Rachel. I know that's been an ongoing issue, an area of interest for Arizona. So hopefully we'll get there. And I really appreciate you advocating and having those discussions internally as well. That's wonderful. This next question, Rachel, reads, what is the likelihood that Access would cover doula services in the future?
Well, now that I think I probably am giving a very similar answer to what Jessica said Blue Cross Blue Shield is doing. We had been kind of holding and waiting for the rules to be written for doula certification and for that program to go live. And now that it has, we are starting a work group. We met, I think, very, very early on to just discuss the beginnings of it, but that was before the rules had been drafted or anything. And we realized we kind of couldn't do much more until we had that information. But now that we do, we have a work group. I think it's going to start like next week, I want to say, to look at all of the many bits and pieces that come with covering a new provider type. And I will say, if you're not super familiar with Access, you should be prepared that these things take a while. It's not a matter of me saying, yes, this is awesome, let's do it. Otherwise, it would look totally different. But that is definitely something that we're working on and working toward.
Okay, and in the interest of time, we have one more question, Rachel, and then we're going to have to move on to our next presenters. This question reads, how do you recommend a practice connects with the various Medicaid plans to streamline how they want to be notified about the positive screening to make sure follow-up can be provided?
Well, I would just recommend, if we're talking about a specific provider, whichever plans that they're contracted with, ask them directly. I don't want to, speak for them on what works the best, since it might vary a little bit plan to plan. But I would just reach out to them directly and ask them, what's the best way for me to connect with you and do this.
Thank you so much. I want to just say that, Jessica, you got a question related to coverage of Blue Cross Blue Shield in Arizona, and you did respond that you have members in all counties in Arizona. And then Nicole, there was lots of positive feedback for you regarding, again, the philosophy of shared leadership and for sharing your perspective on shared and decentralized leadership. And there was also a comment for Nicole saying, thank you, we need to be thinking about CPMs and LMs and their very outdated rules. So lots of stimulating conversation, certainly from the presentations we received here this afternoon. And just really want to thank our presenters, Nicole Gonzalez, Jessica Rigler, and Rachel Sally. Thank you so much for joining us this afternoon.